Hey class, it's Dr. Dorff. Wanted to do a quick lecture that touches on some of the main points of JNC8, which is certainly appropriate this week since you're working on a cardiovascular CDM. Hope you had a chance to look at the PowerPoint that's put up. The first part of the PowerPoint spends some time talking about the differences between JNC7 and JNC8. Good to look at, especially for those of us who have been around, been in the field for a while, and been so used to JNC7. It kind of lets you know what's changed and some of the diagnostic and clinical reasoning behind it. But you're not necessarily going to be held responsible for that material. The main thing that you need to know for practice, for your boards, and certainly for the assignment that you're working on right now, is really what JNC8 is all about. So a quick presentation that kind of highlights some of the main points at JNC8. There is at the end of that PowerPoint, a very good treatment algorithm that's based off of the JNC8 guidelines. That is certainly worth taking a look at or printing out. You can also probably find some online that are maybe like a one-sheet PDF or something like that. So that would certainly be good for quick reference. But anyway, JNC8 guidelines. I really focused on three areas: thresholds, which we'll talk about in a minute. They redefined the thresholds for treatment. Goals for treatment, and drug classes. There were actually 9 recommendations that came out in JNC8. Why they didn't just call it, JNC9, I don't know. Mainly because it was the 8th meeting of this committee. But anyway, I was a bit confusing. JNC8, but there were 9 recommendations. So we'll dive right in. The first one, and this really was kind of a game changer compared to the old guidelines. So general population older than the age of 60. Your ballpark, or not really ballpark, the number that you want to have them at is 150 over 90. In fact, you'll see that if you've looked at the guidelines already, you'll see this repeated all throughout the guidelines. So really a big game changer, and it moved the needle from what it used to be in JNC7. But anyway, general population older than 60, 150 over 90, so they can have a little bit higher perfusion pressures. That's what the committee found, is that as we age and as we get older, that we need we can tolerate first off, and we need a little bit higher perfusion pressures. So that's been bumped up to 150 systolic over 90 diastolic. However, a little caveat here. If you have these patients on a medication or medications for blood pressure, and they happen to be running lower than 150 over 90, that's fine. There is no need to go stop medications to get them up to 150 over 90. So no need for adjustment if they're running lower without any adverse effects. Now, of course, if you have somebody on triple therapy and they have a blood pressure of 100 over 60 and a pulse rate of 58, and they're always coming into the office complaining of dizziness, lightheadedness, and fatigue, then certainly something needs to be modified. But otherwise, no need for adjustment if we're under 150 over 90 without any adverse effects or complaints. Recommendations 2 or 3, essentially the same, focused on patients under the age of 60. And it gave our threshold, new defined threshold of 140 over 90. All right. This also holds true for the remaining recommendations running all the way through number 8. So 140 over 90 is your threshold if we are less than 60 years old. If we are over the age of 18 with CKD, chronic kidney disease, all diabetics. So that is the main focus of these here. Under the age of 60, over 18 with chronic kidney disease, and patients with diabetes, 140 over 90. Now, let's talk in terms of some medications, and specifically drug classes. We aren't going to dive into specific drugs so much. You won't really see that on tests or even on boards, but you need to know your classes. All right. So for the general non-black population, non-African American population, your frontline medications are thiazide, which are diuretics, different types of diuretics. We have loop diuretics, we have others, potassium sparing. These are thiazide diuretics, calcium channel blockers, ACE inhibitors, and ARBs, angioretention blockers. So a thiazide diuretic, hydrochlorothiazide, has a name in it, kind of a giveaway. That was mainly your frontline diuretic in JNC7. If you dive into the literature a little bit more detail, you'll see that there's a push that came out with JNC8 where they resurrected an old thiazide diuretic that had kind of fallen out of favor over the last several years that they now are kind of pushing in terms of frontline, and that's chlorthalidone. So if you see patients on that and you're wondering what that is, it's not a new medication. It's been around for years. It's just one that fell out of favor for a while, and then when JNC8 came out, they started pushing that as mainly being the frontline diuretic to use over HCTZ. So anyway, that's your regimen in terms of initiating therapy in the general non-black population. Now, in the generalized black population, it's thiazides and or calcium channel blocker. So let's talk about chronic kidney disease over the age of 18. This also includes all diabetics. They need to be on an ACE or an ARB. So again, you think renal. Well, these are medications that have renal protection to them, right? They are renally protective medications that also are good antihypertensives and work well at helping to control blood pressure. So chronic kidney disease and diabetes over the age of 18, an ACE or an ARB. You never have them on an ACE and an ARB together. Talk more about that in a minute. So the last recommendation that came out, the 9th one, discussed the initiating and uptitration of medications. So this is to, according to the guidelines, happen over the period of 1 month. So you give them a month. You start them on a thiazide, and then you monitor their pressures for a month. You have them come back. If we are not at goal, depending on ages up here, then you may either increase the dose of your current medication, or you may add a second or even third drug. So that's how you initiate and uptitrate your medications. Like I mentioned up here, diabetics, chronic kidney disease, ACE or an ARB, but never an ACE and an ARB together. Never used together under any circumstance. Also keep in mind JNC8, just like with anything else that we talk about, whether it's diabetes, whether it's cholesterol, lifestyle modifications are key and are still always emphasized. So exercise, that's low salt diet, that's limited alcohol and caffeine intake. So that's basically the highlights of JNC8 in a nutshell. So still look at the PowerPoint that's open, but this really are the highlights and again the main things to remember with JNC8. Now let's talk about the evaluation and treatment of hypertension. So we have hypertension kind of broken out into several different categories. I'm not going to review all of them here. You guys can certainly read about them. The most common one that you're going to encounter in practice is going to be primary hypertension, or what we commonly refer to as essential hypertension. So risk factors for that, it's going to be age, it's going to be obesity, it's going to be a family history. This is certainly genetics play a role in this. Race tends to be more common and associated with greater target organ damage in the general black population. High sodium diet, excessive alcohol consumption, obesity, sedentary lifestyle, diabetes, and dyslipidemia. Depression even plays a role. Other things to consider in terms of secondary causes that could be contributing to hypertension if it's not clear-cut primary or essential hypertension. Need to look at their medications. I always talk about medication reconciliation, asking about what medications they're taking, both prescription, over-the-counter, and supplements. OCPs, oral contraceptives, especially those that have very high doses of estrogen, can not just raise the blood pressure, but can also induce overt hypertension. Talk about that right there. There's OCPs right there. NSAIDs, chronic NSAID use. That's why these two are highlighted right here. And again, our main goal here with evaluation, we're trying to determine the extent of target organ damage, assess the cardiovascular risk factors, identify the lifestyle factors contributing to it, and identifying any interfering substances, primarily medications, not just prescription, but over-the-counter as well. Other ones to consider, of course, NSAIDs and OCPs, your biggest offenders that I've talked about. You also want to look at antidepressants, especially your tricyclics and your SSRIs, prolonged glucocorticoid steroid use, people taking large amounts of decongestants. Hey, North Texas and Oklahoma, not ideal places to live. That people that have allergy and sinus issues. So if we're popping a lot of, and I always ask my patients in terms of when they say they're taking Allegra, I specifically ask them, whether it's Allegra or Claritin or Zyrtec. Are you taking plain Allegra, Claritin or Zyrtec? Are you taking Allegra D, Zyrtec D, Claritin D? Because decongestants will certainly knock blood pressure up. There is a medication specifically designed for people who are part of the high blood pressure club, myself included. I've been on ACE inhibitor since the age of 28. Wonderful gift from my dad. Corsedin, it's over the counter. Corsedin HBP, that's what you want to direct your patients to. Get them off the decongestants. If they're doing any weight loss medications, any of the fad stuff out there. They're doing, Herbalife and stuff like that. And of course, the worthless over-the-counter stuff that they sell at GNC and places like that they advertise as being the greatest thing since sliced bread. It can be bad news. Also, your people that are still on ADD or ADHD medications into adulthood. So stimulants, especially your amphetamines, look at that. Illicit drug use, meth. We have a little bit of a meth problem here in North Texas and in Oklahoma. Can certainly raise blood pressure, so can cocaine. Other things you can look at, and we start kind of chasing zebras at this point. If you look at primary aldosteronism, renovascular hypertension, pheochromocytoma, Cushing syndrome, that stuff you're still going to send off to a hypertension specialist anyhow. Let me think of a few of the more common things that you can see. Patients with obstructive sleep apnea. There's a group of people that are more at risk for systemic hypertension. Endocrine disorders. We just did a whole thing over endocrine. So hypo or hyperthyroid and hyperparathyroid. You can also see them, see those conditions induce medication. So screening these patients, if you look at the 2015 USPSTF guidelines, that's the United States Preventative Services Task Force, it talks about at a minimum adults 40 years of age or older should have their blood pressure measured annually. Adults between 18 and 39 should be screened at least annually if they have risk factors for hypertension. Say obesity, your metabolic syndrome folks, or if they've ever had a blood pressure measurement in the past that had a systolic of 130 to 139, diastolic of 85 to 89. Adults between the ages of 18 and 39 who have had blood pressure recorded that's been less than 130/80 and have no risk factors only need to be screened once every 3 years. Typically, though, what happens, you go in for a, whether it's a sick visit or a wellness visit, over the age of 18, you're getting your blood pressure checked. But those are the official guidelines from the U.S. Preventative Task Force. So, that covers evaluation. Let's talk about physical examination. First thing to get, most important, an accurate measurement of blood pressure. Hopefully in the places where you're doing clinicals at, they're using a manual arm cuff. That is by far the most accurate. Hopefully they aren't using an automated blood pressure cuff where you're at, and if they are, man, hopefully it's the arm cuff and not the wrist cuff. Wrist cuffs tend to run notoriously high. I can't tell you the number of folks that I get who come to me straight from their dentist office because at the dentist office they were there for routine dental work and their blood pressure was 180/100. And so the dentist wouldn't do any cleaning or any dental work, said go straight and see your primary care provider. They come in to see me and their blood pressure is 130/67. And it's because they were using a wrist cuff that probably hadn't been calibrated in 4 years at the dentist's office. Same thing, try to steer your patients away from the I know they're convenient, but the things that they're set up at the pharmacies, at CVS, Walgreens, or Walmart, or whatnot, again, you don't know when the last time one of those cuffs were calibrated. So when you're doing your general physical examination, we're always inspecting. So look at distribution of body fat. Again, we're looking for that metabolic syndrome, that obese patient. We're checking, are they alert, are they oriented, mental status. HENT, one of the most overlooked things in an HENT exam with initial diagnosis and treatment of hypertension is a fundoscopic exam. Very important. I know a lot of you guys still kind of struggling with the ophthalmoscope. It just takes a while to get used to before you can really identify some of this stuff. But here's what you're looking for, and stuff we talked about back in assessment. You're looking for any vitreous hemorrhage. A lot of times you got people who will walk into the clinic and they'll have this bloody eye. They'll be freaking out. They'll think that they're dying. You see that commonly in people that have uncontrolled hypertension, but sometimes people who aren't even hypertensive who talk about allergies, have out of control seasonal allergies, they've gotten to a huge sneezing fit, they can rupture some of the little capillaries in there, and that can cause some hemorrhage, vitreous hemorrhage there. That blood gets reabsorbed just about as quickly as it appears. You tell them it's going to be completely okay, it looks a lot worse than it is. They aren't dying, they aren't turning into a cast member of The Walking Dead or becoming a zombie or anything like that. It will get reabsorbed very quickly. AV nicking, we talked about that in assessment. Look back in your Bates book if you need to look back at any of this stuff. Papilledema and cotton wool spots. So those are the things that you really need to look at and focus on. And again, that comes with time as you get more used to using the ophthalmoscope. In terms of the neck, we're palpating a thyroid. We're assessing for thyroidmegaly, nodules, masses. Again, I mentioned hyper and hypothyroidism can contribute to hypertension, so there we go. Lungs, you're listening for what you normally listen for. You're listening for any abnormal lung sounds. That's what you're on the lookout for. Cardiovascular, of course, you're going to assess rate and rhythm. MGR stands for murmurs, gallops, or rubs. Very important to assess for the presence of bruits in somebody who is hypertensive. Carotid and femoral. Carotid, of course, stethoscope on either side of the neck. You have them hold their breath. Femoral, you don't need to obviously have them hold their breath because they run down where? Either side of the groin. All right. GI, bruits are important as well. That's the main thing you're looking at in GI as well. Look at that abdominal pattern, obesity as well. We talked about that part of the general distribution of body fat. You'll primarily see that in the abdomen. That's where we store most of it. So you're looking for abdominal pattern obesity. And then bruits over the aortic bruits or renal arteries. Again, that comes with time. You have to have a really good stethoscope, and it just takes practice to be able to get that down. Then we get down to extremities. You want to assess peripheral pulses. I typically, in all of mine, I do brachial, radial, popliteal, femoral, dorsalis pedis, and posterior tibialis pulses. Again, what would normal peripheral pulses be like? You would name off all of those, and you would say we rate them on a number scale, so they should be 2 plus or plus 2, and hopefully they are symmetric, right? So asymmetry, you need to get your radar up. So that's what we're looking for, and then of course assessing for the presence of any edema. Also, I guess up here in the CV, you could also be on the lookout for JVD, jugular venous distension. So be looking at that. And then for neuro, you're going to be assessing for confusion, any visual disturbances. That's why the fundoscopic exam is so important up here under HENT, and any focal weakness or deficits. So that kind of covers the highlights of physical exam on a patient that is new diagnosed with hypertension or is hypertensive. So you should do all of this. At minimum. Certainly there's other stuff that you can do as well, but these are just some of the highlights that I wanted to point out in terms of the hypertensive patient. So that leads us to the workup. Let's talk about labs. So typically you're checking electrolytes, serum creatinine. So mainly and the serum creatinine is to calculate an estimated GFR, because we talked about how important kidneys were. That's why we talked about everybody who's over the age of 18 that has chronic kidney disease or diabetes. They get what? An ACE or an ARB. So you want to make sure you have that calculated GFR. So in terms of, hey, so do I order a survey 8 or a survey 14? There's really not that much of a price difference between the two. I typically just order a survey 14 or a complete metabolic panel because I'm also wanting to check and make sure that, because that gives you liver functions. You can order a survey 8 or a BMP plus LFTs. I typically just order just a 14, just get it complete, and that way I have my liver on there, because a lot of times these patients are also going to be with metabolic syndrome. Now we know hypertension, we know hyperglycemia, we know hyperlipidemia. So if you're going to be initiating a statin, you want to have a baseline for liver functions, and if they're already on a statin medication, of course there's it can be hepatotoxic, as you just found out with the LFT lab that you recently completed. So there we go. So it just says licensed serum creatinine. I typically do a 14. You also want to try to get them, hopefully they come in first thing in the morning, they happen to be fasting. If not, you have them come back the next morning and you get a fasting blood glucose. If that's abnormal, you're going to follow that up with what? A hemoglobin A1C. Again, going back to your metabolic syndrome patient. You want to check a UA, check a urinalysis. We're looking for things such as proteinuria. Are the kidneys really getting squeezed here? We talked about earlier on the previous picture. By the way, you guys got the my 3rd grade. I think I've graduated up to maybe about a 6th or 7th grade level now, though. I try to clean it up a bit for you. But you can thank Aubrey Stiles because she likes these so much, the handwritten stuff. So that's why you got this again. So we're looking for proteinuria again on the previous one. Again, because of renal issues and the role that diabetes plays and can affect the kidneys. So we're checking that. So we're also going to check lipids. So again, if they happen to not be fasting, I usually will give them the option, hey, we can check some of this blood work now, but hey, better off and try to prefer one-stop shopping. Patients rather would only be stuck once than have to be stuck twice. So I typically say, hey, if you can pop back in first thing tomorrow morning, tell them nothing to eat or drink for 6 hours prior to coming in. They can take their morning medicines if they want to with a few sips of water. That's great. And that way you can get all of this stuff done all at once. Makes a patient happier too, because they don't have to get needle sticks in consecutive days. And then you ensure you have your fasting glucose as part of your survey. And you also get your fasting lipid panel in there. And then an EKG. That needs to be standard on, and don't care whether they're having chest pain or not, or complaining of dyspnea with exertion, but EKG is standard for your initial workup in terms of labs and diagnostics for somebody who is being diagnosed with hypertension. Also consider chest x-ray. This used to be a must-do. Now it's more of a consideration. I typically still do it because one of the common abnormalities that you find on somebody that has uncontrolled hypertension that you'll see represented on your EKG is LVH, which is left ventricular hypertrophy. That can lead to heart failure if not identified early on. So you typically in patients that do have LVH, in addition to seeing that show up with EKG changes, they're typically your patients who on chest x-ray are going to have gross, what do we call in the large heart? Cardiomegaly, right? So that's why the chest x-ray comes into play on that. And then if you do have somebody that does have LVH on their EKG, you want to get an echocardiogram, because again, if they have a big boggy heart and they have LVH, that means the heart's having to work a lot harder to squeeze blood out and perfuse. Remember that we measure the heart, we have ejection fraction. So you want to get an echo so you can measure that ejection fraction. That's basically the rationale behind that. Again, I will post these as well so you have them to look at. But again, just a brief rundown of the JNC8 guidelines, and then just some points that I wanted to highlight in terms of treatment in the clinical setting. Now, a couple of quick things that you will not be held responsible for or tested on, but I know people have asked me when they've done clinicals with me, and I think even Dr. Bloomquist mentioned this when he lectured, that he just don't bother with the diuretics, just stick everybody on an ACE or an ARB. There's some, and I kind of do the same thing. If I'm going to start somebody, rarely do I set, and here's the reason why. In terms of monotherapy alone, you probably are not going to get somebody at goal with just a diuretic. You're going to have to add something else into the mix. The other thing as well is the way that I approach things. I'm all about compliance. There's the difference between textbook medicine and real world type kind of stuff. So we've talked about our guidelines. We know what our thresholds are. We know what our treatment goals are. None of that means anything if somebody's not going to take their medication. If they keep it on their kitchen countertop or in their medicine cabinet instead of sticking it down their throat, it doesn't do you a lick of good. So if somebody comes in there, you diagnose them, congratulations, you have hypertension, I'm starting you on medication, and they don't feel bad at all, they're asymptomatic, but they've had these consecutive blood pressure readings that have been elevated. You start them on a medication, and you start them on a medicine that makes them pee all the time. What are the chances of them staying compliant with that medication long term? Not all that great. If you take some time to let them know that, hey, this medicine's going to make you got to go, you will get used to it, which they typically do after a few weeks, but not all the time. But so that's one thing to consider, is that if they're having to get up and go all the time, they may look at you as like, after doing that for a few days, well, I didn't have this issue before I went in to see that crazy bald guy, and give me this medicine to make me have to pee all the time, and this is driving me nuts. So forget this, I'm not taking this anymore. They throw it in the trash, and they don't come back to see you, and they don't take their medication, and down the road you hear from a friend of yours who works in the ER, hey, a patient of yours rolled in the other night with a big old honking stroke, their blood pressure was through the roof, there you go. So So that's how I approach it. And again, from a monotherapy standpoint, rarely do diuretics get you to goal alone. You typically have to add something else. So I'll typically go ahead and start a ACE or ARB, as long as they're not African American. If they're African American, I start them on a calcium channel blocker. Another thing, we talked about the up titration of medications. If over a month you don't get them to goal, you need to add a second medication. You want them to you want to split those medications in terms of your dosing, and by that, it doesn't matter which one that you choose to give when, but you want to split it up to a BID dosing. Have them take one in the morning and take one in the evening. There is a phenomenon called nocturnal dipping. You can look this up on your own. It was discovered by a group of cardiologists in Europe, I believe in Spain. Europe's always way ahead of the ball game in terms of North America. But they had discovered that once patients enter REM sleep, the body kind of goes into a rebooting mode, so to speak. Typically it tends to occur between midnight and 2 a.m. Again, that's dependent upon when someone actually goes to sleep, though. And what happens, the body kind of reboots, resets itself like a computer. People that are normotensive get what's called a nocturnal dipping effect, where their blood pressure will lower by about 15 millimeters during that rebooting period, which they found makes for more consistent and better blood pressure control throughout the course of the day. People that are hypertensive, they take their lisinopril first thing in the morning. It's out of their system by the time their head hits the pillow. So they're running above, because you need to be, again, at a normotensive level to get the benefit of this nocturnal dipping effect. So if you're running elevated and that little reboot command comes and you're running high, you're not going to get this. It's just going to come by. It's going to tell the body to reboot, but you're not going to get the benefit of that nocturnal dipping. So you want to try to turn your patients into nocturnal dippers. So if they're on 2 different agents, dose one in the morning, dose one in the evening. I would also greatly recommend that if you do amlodipine, the generic for Norvasc, calcium channel blocker, for those of you that don't know that yet. It's a medication that's been proven to work better at night. It's also, one of the side effects of the medication is it can cause swelling, peripheral edema, primarily hands and feet, especially when you get to a 10 milligram dose. 5 milligram dose, not so much. 10 milligram dose, they're going to swell up like a blowfish. You can help mitigate that by dosing it at HS. And then they also get the benefit of being a nocturnal dipper. Or, like I said, if you have somebody on multiple agents, you have them on 3 agents, make sure you're giving at least one of those agents, or 2 if you can, at an HS dosing. And again, you get the benefit of nocturnal dipping. And again, if you think I'm making that up, you can look it up on your own, and you'll see where that's addressed. So that's that's one benefit of dosing medications at HS, and it makes for better control of more consistent control of pressures throughout the course of the day, which of course reduces our risk for an adverse cardiovascular event, which is the name of the game. So that's pretty much all I have. If you guys have any questions about anything, of course, as always, call me, text me, shoot me an email. I hope you find this helpful. I will try to post a similar lecture tomorrow night, covering the highlights of dyslipidemia, primarily focusing on the ATP3 guidelines. What the highlights of those are, if you guys want me to, if you find that helpful. So let me know. So hope you guys are having a good week. Any questions, let me know. I'm always available.